Complications are the part and parcel of procedure. Matters how you tackle it. Next presenter is Dr. Imran Iftikhar from RIC Hospital. Title is When OCT Save the Day.
Bismillahirrahmanirrahim. Assalamu alaikum. Good afternoon, everyone. I am Dr. Imran Iftikhar, working at Rawalpindi Institute of Cardiology. Today, I'll be presenting a case of ACS in which imaging came to, in the form of OCT, came to our rescue. So first, a brief history of the patient. A 36-year-old gentleman, non-diabetic, non-hypertensive, presented with 6 hours history of chest pain, widely stable with ECG showing T-wave inversions in anterior leads and mildly raised troponin levels. And echo showed mildly impaired LV function with mild lag in mid and apical anteroseptal segments with ejection fraction of 50%. So he was taken to the cath lab for angiography. So these are the still images of the angiogram. You can see there is an eccentric plaque in the osteoproximal segment of the LAD, and rest of the coronaries were normal. RC, although not shown over here, it was also normal. So these are the clips from the of the patient, and you can see that there is a small segment of LAD involving the osteoproximal, and it's a critical lesion. So at this point of time, we were in a doubt that whether to stent this patient or not, because if we stent this, considering that it is an atherosclerotic plaque, then definitely patient would have to take dual antiplatelet therapy for at least for 12 months. And the other differentials were that it could be SCAD or it could be IMH, and we know that SCAD or IMH can present with ACS as well. And if it's an SCAD or IMH, then we can go away without stenting, and then we can keep the patient conservatively, and then we can redo an angiogram after 4 to 6 weeks, and we can avoid dual antiplatelet therapy, and which will patient have to take. So what was the way forward? We need to define the diagnosis. We need to define what was the cause of this presentation. So we concluded that to go for imaging. So we had OCT available at REC. So we went with the OCT run, and you can see that in a still image there is an atherosclerotic plaque with heavy thrombus burden, thin fibrous cap atheroma, involving the ostium of LAD, and OCT also helped us in knowing that the extent of plaque, it was not only involving the ostium of LAD, but it was also extending into the distal LMS as well. So this is the clip OCT run which we did. So you can see that there is a heavy thrombus burden in the ostium of the LAD, and there was no SCAD or there was no intramural hematoma. So based on the OCT findings, so this young patient had flow limiting stenosis in the osteoproximal segment of the LAD. Rest of the coronary arteries, they look pristine and with no angiographic evidence of stenosis. So considering the patient's age and that he was non-diabetic, non-hypertensive, there were no known premorbids, and there was strong possibility that it could be IMH or SCAD. The other differentials were obviously a ruptured atherosclerotic plaque resulting in NSTEMI. So it was important for us to differentiate between the two, as with IMH and SCAD we could avoid stenting. So based on the OCT findings, we went for stenting, and we took a stent of 424 deployed from LMS to LED, and we then did the post dilatation with 4.5 into 12 NC balloon. And after stenting, definitely we did the this was the final result. You can see a well deployed stent, and then we did the OCT run. These were the final OCT images, and you can see that there are well opposed stent struts with adequate MSA in both LAD and LMS. So take-home message: in young patient with NSTEMI can be a manifestation of IMH or SCAD, although it is more common in young women, but still it's not uncommon in young males. So differentiating SCAD from ruptured atherosclerotic plaque is important, as the management plan differ in both cases. So OCT with its improved resolution, it helps in differentiating SCAD from ruptured thin cap fibrous athyroma, and hence it can guide us in the further management of the patient. So as in our case. Thank you.
Do you perform POT of the left main?
Sorry?
Do you perform POT of left main?
Yes, we did the POT in the LMS, and after that we did an OCT, and it showed.
What size of balloon you took it?
So we took a 4.5 into 12 balloon.
12 तो मेरे ख्याल में स्टेंट जो आपने पीछे लेफ्ट मेन में था, that was not 12 mm.
So
left in the left main.
This was the shortest balloon which was available, so we had to do with that. Ideally, it should have been.
So when you are like taking on this case,
Intramural hematoma.
so when you are taking on this case, like the discussion can be कि आपने left main को बाहर ostium तक cover करना है या सिर्फ एक port की जगह छोड़नी है, that can be a discussion. लेकिन आप लेफ्ट मेन के अंदर जब आ रहे हैं तो पॉट की जगह ज़रूर छोड़ें, अपने स्मॉलेस्ट बैलून जितना ज़रूर आए ताकि आप उसको पॉट कर सकें.
Agreed.
आपके सेंटर में आईवस अवेलेबल था?
Yes, IVAS was available.
आपने प्रेफर क्यों नहीं किया आईवस को? Why was OCT preferred in this case?
So we know that OCT's resolution is far better than the IVAS, and we know that OCT basically helps us to define the plaque morphology better as compared to IVAS. So OCT is always preferred when we need to know the plaque morphology.
Spontaneous coronary dissection में वो superior है OCT.
So there is no clear-cut data that whether in SCAD the OCT does harm or not. So OCT is safe even in SCAD.
बट इट्स अ गुड केस ऑन दिस पार्ट के हम जैसे कल डिस्कस कर रहे थे कि यंग पेशेंट जिसकी बाकी सारी वेसल्स नीट हों उसमें आप स्कैड को कंसिडर करें, तो आपने इसमें ये शो किया कि ठीक है स्कैड को कंसिडर करें लेकिन इट इज़ नॉट ऑलवेज स्कैड, लाइक यू हैव टू डू इमेजिंग एंड देन यू हैव टू सी.
एंजियोग्राफिकली तो नहीं लग रहा था बिल्कुल भी. इतना लग रहा था किसी को.
So SCAD की there are 3 types of SCAD. Type 1 and type 2 looks like a dissection, but in type 3 it looks like an atherosclerotic disease. So different types in SCAD की. उसमें से one form is atherosclerotic, looking like an atherosclerotic. Sorry? Yeah.
Well, it can be discussed. I think most of us would have not stented it, considering it that it's a
Yes.
most of us would have stented it right away. Yeah.
So this was the basic idea that if it's SCAD or IMH, definitely we don't need to stent it. We can keep the patient, manage the patient conservatively, and we can avoid the stent and all those things.
Nicely case done.
Thank you.
The SCAD normally doesn't involve the osteoproximal segment. It's normally involve the proximal LAD, proximal to mid LAD, not the osteoproximal segment of LAD. Just a comment about. Second, can you please show us your first image before the angio? What was the reason for stenting from left main into LAD? Was there not enough landing zone?
Yes, so probably they are not showing.
ये presentation दोबारा चला है.
One more question.
Of course, there is a landing zone, and you can take a view of RAO 40 and caudal 40. You can see the ostium of the LAD.
वो images दिखाए. OCT images. हाँ.
यहाँ पे आप देखा ना इसमें या तो इसको कम से कम 8 mm या 12 mm इसको पीछे लेके आते तो हम पॉट भी अच्छी तरीके से कर सकते थे। तो इस तरीके से जो है ना हमारा लेफ्ट मैन को हमें ऑनर देना चाहिए कि द स्टैंड शुड बी वेल अपोज्ड।
No, it was not outside the scented area.
आप देखें, look at the stand not a tall 12 mm behind in the left main. It is of small size. Look at the.
It doesn't matter if they have post dilated the left main stand, they have not disturbed the non-stanted segment, and they have the
डिस्टर्ब तो हुई होगी ना, लाजमी डिस्टर्ब हुई होगी। लुक एट द
have the
स्टैंड।
OCT. You have the OCT. You have seen the stand is post dilated. That's fine.
Yeah, we did the OCT run after
You have
it's
the
been
OCT
stanted.
luxury and you have post dilated.
Sir, yes, you can reassess by OCT after standing.
Dr. Jabbar, you want to add something?
One more question from Imran Iftikhar. Didn't you go for FFR in this case in such an intermediate lesion?
No, since it was a presentation of ACS, so I think the FFR is not validated in when it's ACS.
This is the case that we did. This was an interesting case in a way that imaging helped in a number of ways. The first important thing was extent of the disease. We saw with the OCT that the disease was extending into the left main with a plaque burden of more than 50%. So covering the left main was the way to go forward. And secondly, the morphology was very important because with pristine arteries in a 35-year-old gentleman, stenting, not stenting, whether it's erosion, atheromatous plaque with rupture, or whether it is a SCAD, it's very important to delineate because if you put in a stent in a SCAD patient with an IMH, you know the tooth pasting effect can happen, the IMH can progress back into the left main, it can progress forward. So in this young gentleman, it's very important for us to delineate and to see what's the. And as far as the port question is concerned, it's well taken, but it is more impertinent, the port, when we are doing a bifurcation stenting procedure. We are not recrossing into the circumflex because the circumflex is very healthy, the angle is very good. So taking a 4.58 balloon or 12 balloon would not have made much of a difference because we were post-dilating the vessel anyway, the ostial LAD as well as the left main. Yes, your question would have been pertinent if you were doing a up-stent, two-stent strategy, then a small, shorter port balloon and then recrossing into the circumflex would have been appropriate to avoid any damage to the bifurcating segment. So this is why this OCT was very important. You could have done an IVUS, as you said. It is a complementary kind of, but OCT with its improved resolution of within the vessel or luminal structures, it gives us a very good picture of what's going on in this patient. So this is how we proceeded with this case.
Thank you.
माइक में बात करें सर.
I would not rely on FFR at all. Even if it is 50%, it has caused ACS, ostial LAD. I think
वहाँ पे तो उसमें इन्फ्लेक्ट क्या होगा ना, तो लाजमी हम जब 4.5 से करें तो 20
माइक दें प्लीज.
आदमी वो उस पर आने का।
So another interesting fact in this was whether it's a plaque rupture or whether it was an erosion. So how you define both, it's very important to know. Plaque rupture is the disruption of the plaque with the cavity formation in the O-line thrombus. So in this case, a lot of the thin cap fibroaderoma was covered with a thrombus. It was easier for us to do a thrombus aspiration and go forward, but the proximity of thrombus was very critical. It was very close to the circumflex. And as you all must be knowing that if we do a thrombus aspiration, there's high risk of thrombus propagation to the circumflex and completing the case. So it was difficult for us because there was a lot of thrombus burden. And in that case, a lot of maybe the underlying thin cap fibroaderoma would have been covered by the thrombus. So we were not able to differentiate, but whether it was erosion or whether it was a plaque rupture, since the location was osteoproximal, so I think stenting was the way to go forward in this case. But erosion can also come up and cause NSTEMI because it can cause, in 30% of the cases, it can be the.
I was pointing because if this was erosion, you can have treated conservatively because the study.
What was the MLA after standing?
That erosion versus plaque.
So sir, since Dr. Jabbar.
Conservative.
I agree with Jabbar that we can even in erosion we can go away with standing and we can leave the, but osteoproximal left main में 50% plaque burden है. So this gentleman had atherosclerotic heart disease and a prognostic vessel. So not to stent was, I guess, it was very tricky. The only concern was if it was eye-match, then it was been safe to leave it and then re-image after about 6 to 8 weeks and see how the patient is going on. But yes, if it was a RCA or if a distal LED even or circumflex mid to distal coast, then we would have left it if it was a erosion.
Thank you.
Dr.
very
Imran,
much.
what was the MLA after standing?
So MSA was, I don't know, remember the actual values, but it was in LED it was around 8 and in LMS it was around 11.
It was
So both were adequate. So we require at least 7 in LED and 8 millimeter square in LMS.
and you went with 4.5 NC pod balloon.
Sorry?
You went with
4.5 into
NC
12.
balloon
4.5
in
into
left
12.
main,
In left main.
and it was achieving the area of MLA of 8.
More than 8.
Okay.
Thank you very much, Dr. Iftikhar.